Welcome everyone. I'm Katie Arnott, the Executive Director at Canadian Doctors for Medicare, and we're really honored to have such an esteemed panel with us, as well as all of you joining us this evening or afternoon if you're on the West Coast. Just before we get started, I wanted to run through a few housekeeping matters. We are recording this webinar so that it can be shared with those who couldn't join us today. And please feel free to engage with one another in the chat box, introduce yourself, tell us where you're calling in from. And you can also ask questions through the Q&A function of Zoom at any time during this webinar. We will have a lengthy Q&A session later on in the meeting. So with that, I would like to hand it over to one of our board members, Dr. Farah Kumar, who will be moderating this event.
Thanks, Katie. Welcome everyone. I'm Farah Kumar. As Katie mentioned, I'm a CDM board member and a physician based in Red Deer, Alberta. I'm really excited for the opportunity to be moderating this incredible panel tonight. So thank you all for joining us for this webinar about the future of pharmacare in Canada. We as CDM are very excited to be hosting a webinar on this topic. It's been a key area of policy for us for many years now. And we're really excited to see the number of people that are taking the time tonight to engage with us on this important issue. So thank you to all of you. We've worked with many organizations and individuals, including our esteemed panelists tonight, for years to raise the profile of pharmacare and educate the public on why we need universal access to prescription medications. For anyone who might be new to CDM, we are a nationwide evidence-based, nonpartisan member organization dedicated to strengthening and preserving Canada's publicly funded healthcare system. Our mission is to provide a voice for Canadian doctors, residents, and medical students who want to strengthen and improve Canada's universal publicly funded healthcare system. And if you are a medical student, resident, or physician on the line, and this is your first interaction with us at CDM and you're not yet a member, please do consider joining today so you can stay engaged with us on pharmacare and other topics that are important to Canada's public healthcare system. We will add a link in the chat box to where you can become a member if you choose to do so. So we have three great panelists on tonight's webinar and not a lot of time. So let's get started. They all need little introduction, but we will do our best to do their esteemed careers justice. Dr. Steve Morgan is Canada's leading expert on pharmacare systems. His research has sparked national debate about how universal pharmacare can provide all Canadians with access to appropriately prescribed, affordably priced, and equitably financed prescription drugs. Dr. Morgan has published over 150 peer-reviewed research papers. He regularly provides policy advice to governments across Canada and has served on advisory committees of international agencies such as the World Health Organization and the OECD. Dr. Jane Philpott is the Dean of the Faculty of Health Sciences, Director of the School of Medicine at Queen's University, and CEO of the Southeastern Ontario Academic Medical Organization. She is a medical doctor and former member of Parliament. Prior to politics, Jane spent the first decade of her medical career in Niger, West Africa. She was a family doctor in Markham Stouffville for 17 years and became the chief of family medicine at Markham Stouffville Hospital in 2008. From 2015 to 2019, she served as Federal Minister of Health, Minister of Indigenous Services, President of the Treasury Board, and Minister of Digital Government. She currently serves as the Minister's Special Advisor for the Ontario Health Data Platform. And Linda Silas has been the president of the 200,000-strong Canadian Federation of Nurses Union, or CFNU, since 2003. As the dynamic and charismatic leader of Canada's largest nurses organization, Linda is recognized as the foremost advocate on behalf of nurses in Canada. Starting her tenure as a full-time labor activist as the single mom of a 13-year-old son has shaped Linda in a very distinctive way. Linda has earned a reputation for being a caring listener who is focused and solution-oriented in everything she does. A proud New Brunswicker, Linda credits her home province for both her impressive work ethic and her well-known zest for life and adventure. So thank you so much to all of our panelists for being here tonight. I know we're in for a very rich discussion. First, we'll hear from our panelists about the current state of pharmacare and the evidence that supports it. And then we'll move to a Q&A session with audience-driven questions. Throughout the meeting, you can pose questions in the Q&A box, and we will pose those questions to our panelists in the second half of the webinar. So without further ado, Steve, if you don't mind starting us off, could you please provide us in about 10 minutes or so with a bit of an overview of the state of the push for pharmacare in Canada and some of the research you've done into the economic arguments for the program?
Sure can. Thank you very much for the invitation to speak to you. It's my honor to be speaking to you from the traditional, ancestral, and unceded territories of the Coast Salish people, the Squamish Nation in particular. I'm going to try to give you a very brief overview of the Pharmacare 101. It was my remit, so bear with me. I begin all of my talks on this topic with this slide here, which is the announcement and formal declaration of the Universal Declaration of Human Rights in the post-war era. And what the reason that this is meaningful and the subsequent ratified conventions and covenants of the United Nations and World Health Organization is that they all have made it very clear that health is a fundamental human right and access to healthcare, including access to necessary medicines, is a human right. And as a consequence, countries around the world have an obligation to provide all residents of their country equitable and universal access to necessary prescription drugs. Consistent with that, then, every high-income country with a universal healthcare system provides universal coverage of prescription drugs. Every such country, with the exception of Canada, that is. And I know I'm speaking to Canadian Doctors for Medicare here, and I know that you will agree with me that if Canadians take any pride at all in the ethics and the values of our universal Medicare system, so to speak, we really ought to be ashamed of the fact that we don't have an analogous system for prescription drugs in this country. I'm going to try to talk you through how we got there and what it means. The main thing to know is, as you know already, that overwhelmingly Canada finances medical care and hospital care through a universal public health insurance system, which we know as Medicare. That insurance system was not meant just to cover those components. The plan was to develop it in stages, and that after those two stages were established in the 1950s and 60s respectively, the system was to expand to prescription drugs, home care, Dentacare, and other things. Unfortunately, we never got there, and so today, 43% of prescriptions in this country are financed through the public system, and the majority of prescription drugs are actually financed by people out of pocket or by private insurance plans, which they purchase on their own. One of the very troubling things in Canada is the complexity of our system. There are more than 100 different public drug plans in Canada. I like to argue that these are akin to little umbrellas that the provinces and territories had erected over different points of the last 60 years to provide medicine coverage for very specific populations defined by the age, income, or disease needs of particular households, but not a single umbrella in any single province around the entire country. We also have thousands of even smaller, much more exclusive umbrellas, which are the umbrellas that cover employment groups in Canada. Private insurance in this country is overwhelmingly obtained through work-related compensation packages. And each of these umbrellas is an insurance program for specific employee groups. And if you're in a large organization, including my university, for instance, there may be multiple of these umbrellas, multiple insurance plans for the multiple different employee groups. So we have a system that is a patchwork of literally over 100 public programs and thousands of private ones. And the real shame among this is that it leaves about 1 in 5 households in Canada with little or no coverage at all. They either have no coverage for the prescriptions they need, or they have inadequate coverage because the coverage they may qualify for, typically through public programs, requires that they maybe have to pay 3 to 5% of their household income on their medicines before public coverage kicks in. So we have this patchwork system, and I want to ask the question and provide the data on how we compare to countries that have essentially a universal single umbrella for pharmaceutical coverage for the entire population of people who reside in a given jurisdiction. The punchline to this question in terms of how we fare is not well, and it's pretty obvious because of the patchwork of ours. You could just think logically a system involving thousands of different plans that are managed independently, financed independently, and leaving 1 in 5 people between the gaps is not going to be a system that is desirable for any country. But to give you some specific data, I want to talk about 3 of the main outcomes of interest in the pharmaceutical system. That's access to medicines, that is fulfilling our obligation under the Right to Health framework. The cost of the system, because any system that is going to provide access to medicines needs to be sustainable over time so that we can continue to provide that access generation after generation. And we want to talk a little bit about financial equity and risk, the financial burdens that are placed on individual households and employment groups, including employers, that stem from the system of financing in Canada and comparator countries. I want to, went the wrong way. I want to look at a selection of countries in blue here that are countries that have systems of health insurance that are fairly similar to Canada's. These are countries with single payer health insurance systems that is comparable to Canadian Medicare, but those systems also include single payer coverage for the prescription drugs that are used by patients covered under that system. And those systems involve relatively low co-payments for the prescriptions that people use. I've got Canada and then Quebec as comparators here. Quebec in part because, as many of you know, there's a system of mandatory private insurance in Quebec that many insurance industry spokespeople and pharmaceutical industry spokespeople would like Canada to adopt. And I'll show you some data on the outcomes there. So very quickly, the number 1 outcome of interest, access to medicines. How many people in these countries report that they can afford to fill the prescriptions that have been written to them by a healthcare provider? It turns out not very many in Canada by comparison to other countries. This is 2016 data from the Commonwealth Fund's International Health Survey, reporting the percentage of adults in the population reporting that they could not afford to fill the prescriptions that they had been given in the previous year. The keynote here, and you've heard it before, is that about 1 in 10 Canadians can't afford the prescriptions that they're given. And this is true also in Quebec, that even though they have universal insurance in Quebec, they have very high deductibles, insurance premiums, and co-payments. And as a consequence, Quebec doesn't fare particularly well. In comparison to the international countries, we are very high. The rates of cost-related non-adherence, as we refer to it, are quite low in comparators, particularly the United Kingdom, which has a very comprehensive public program with very little co-payments for patients filling prescriptions. And just to give you an idea of these bars, if Canada could bring itself down from the red bar to the green dotted line, which is the average of the comparator countries, 2 million Canadians would be filling prescriptions that they are currently foregoing. The Advisory Council on the Implementation of National Pharmacare, or the Hoskins report, estimated that this is costing our hospital system approximately $1 billion a year in wasted visits and resources to the hospitals on just a few ambulatory care sensitive conditions that should be better managed with medicines. The CFNU sponsored some research that showed that this also was costing somewhere between 300 and 700 premature deaths in Canada every single year. So this is a very significant financial and human toll that these gaps in coverage create. What about the cost of the system? What's really kind of galling about these gaps in access is you can't say that we're doing this because it's saving us any money. We actually have the most expensive system of drug coverage amongst comparator countries. And Quebec has by far the most expensive system because by design it was created to provide essentially a blank check to the pharmaceutical and insurance industries. So to give you a sense of what this is per capita spending on prescription drugs in Canada and those comparator countries, if we were to adopt the Quebec model at the national level, that is to go from the red bar to the gray bar, that system would cost Canadians $5 billion a year more than we're already paying on medicines. But if we were to come down, even just down to the level in Australia, which is the most expensive of these universal pharmacare systems that we're looking at today, even if we just reached Australia's level of price and utilization, we would actually be saving $7 billion every year. And remember, we would be getting better access to medicines in terms of the percentage of people who could fill the prescriptions written for them. To give you an idea of what $7 billion a year of savings means, That's enough to pay reasonable salaries for 25,000 doctors in Canada and to pay those salaries forever. So the money that we're squandering on an overpriced patchwork pharmacare system has a real opportunity cost. It is real money that could be invested elsewhere in the healthcare system or elsewhere in social determinants of health. Lastly, just want to look at financial equity and risk, because this is something that is important, although it's the kind of things that sometimes gets overlooked. And that is the amount of money in our systems that actually comes out of the pockets of households or that is uninsured in employment groups. That is, that specific employers and their unions bear the cost without insurance pooling across a population or government subsidy. These numbers are fairly staggering. By design, Quebec's system has a very significant burden on households and employers because it's designed to do that. The systems in these comparator countries, much like Canadian Medicare, were designed to make sure that we pay for the services as a community, and therefore individual households and individual workplaces don't bear those burdens. This is very significant in terms of the real impact on the lives of Canadians. Recent surveys of Stats Canada have estimated that approximately 1 million Canadian households foregoes expenses for food and housing in order to pay for the prescriptions that that household needs. That's just a staggering thing to ponder in terms of the prevailing ethic of Canada's Medicare system. And it seems to be antithetical to the principles that we would hold our health system to if it were talking about things like medical services and hospital care. So to sum up that evidence, the 101 version of pharmacare is that our patchwork system of prescription drug coverage provides worse access to medicines at higher overall costs and with greater financial inequity than any of the reasonably comparable universal public pharmacare systems do. And I say this, and it's true, this is a rather depressing fact. But it's also something that we can look forward to as a glimmer of hope, because if you think about it and turn this on its head, it actually proves that this can be done because every comparable healthcare system in the world does it. They get better outcomes and they pay lower prices at greater financial equity than our system does. I just very quickly, and I know I'm going a little bit long here, want to just remind you, this is not a new and radical idea. Dating all the way back to the Hall Commission in the 1960s, it has been recommended that a single payer system of paying for medicines in Canada would be the most financially prudent and the most equitable. And we have had 4 national inquiries in the last 25 years on this subject. All of them have concluded the same thing, that a universal national system of prescription drug coverage would in fact be the best system within the context of the Canadian Medicare system. It would be likely managed by the provinces, but significantly cost shared with the federal government to ensure national standards were upheld. And again, this has been repeatedly recommended over time. The last thing on financial stuff, you think like, what are the costs? You probably heard these statistics from the Hoskins Advisory Council on the implementation of national pharmacare. Their proposed model of pharmacare would say provinces just spend what they would otherwise be spending on their current drug plans, have the federal government put $15 billion of new federal money into the program so that those plans can be universal and comprehensive, and the private sector would save $20 billion a year as a result. So the net price to Canada is actually $5 billion in savings, not in costs. And that doesn't include indirect savings to the healthcare system. So I leave you with this thought as we ponder the politics and opportunities here, recognizing that pharmacare is actually a cost-saving program. That the question for national policies is not, is it pharmacare or another national policy in, for instance, the next election cycle? It's pharmacare and another national policy, because pharmacare literally saves the money that you need to do the other thing. So thank you very much for that. I apologize for going a little bit over time.
No, that was fantastic. Thank you so much, Steve, for that really helpful and eye-opening overview of the situation. That's such a great way to start our conversation. Next, we'll hear from Dr. Jane Philpott. Jane, the issue of universal prescription drug coverage has become incredibly popular with the public over the last number of years. Could you shed some light for us on what you think it will take to actually get this implemented?
Well, thanks very much. And it's a real pleasure to be with you and to see lots of terrific folks here from across the country. Thanks for those of you who have given a bit of a shout out as to where you are joining us from. Like many of the people who have already chimed in, I am joining you from Kingston. And as has already been acknowledged in the chat, Kingston sits on the shores of beautiful Lake Ontario. It's the traditional territory of many Indigenous peoples, including in particular peoples of Haudenosaunee and Anishinaabeg heritage. The Huron-Wendat also spent time over the centuries in this territory, and I want to particularly acknowledge those who have cared for the land and have now with whom we now share the land. This is a land that actually was released by the British Army in the late 18th century under the Crawford Purchase with the Mississaugas peoples, and there is no treaty that it currently exists to acknowledge the details of that Crawford Purchase. And so I want to acknowledge that this is land that, well, subject to that particular arrangement, land that belongs to other people. And I am pleased to be able to share this land today and acknowledge the peoples who share it with me. And so going after Steve Morgan is really easy because Steve basically told you everything you need to know about pharmacare, which is fantastic. And I'll just add a few other details. And I know that Tara, you really wanted me to specifically talk about sort of where do we go from here? How do we actually implement this? Because the evidence is all there, as Steve already said. So I was going to give you a little bit of background on some thoughts that I've been having about pharmacare in recent months, particularly through the pandemic. I also want to touch a little bit on a piece of policy work around the pricing of drugs, because I actually think it's relevant in terms of how we're going to make progress and convince politicians to be able to do the right thing. And then I'll give a few sort of hints around advocacy thoughts at the end. So, you know, I feel a little bit like Steve. I feel a little bit discouraged, I have to say, at the moment, because I think there was a lot of optimism at the beginning of this current 43rd Parliament that this was maybe the Parliament that was going to actually see the implementation of pharmacare. Was in, the details were there. People like Dan Raza and others wrote fantastic stories about how everything was all set up, just the same situation that we were in back in the day when Medicare came into its fullness, where there was a minority Liberal government and the NDP there to kind of push along the policy work. And then, of course, along came the pandemic, and I don't think that that's a good enough excuse, but I think that is part of the reality that has been grabbed hold of by those who could have used this time, especially this time of massive federal spending, to say, hey, while we're at it, here would be a really good way to do some federal investments that would have a big impact on people's lives and would not overall be have a massive impact on the federal deficit at a time when deficit spending has been accepted by Canadians as a necessary approach to being able to deal with the fiscal situation. So we're all feeling a bit sad, I think, that the progress that seemed to be underway has been sort of set aside. And I won't reiterate all the details that Steve went through, but there's no question that Canadians continue to struggle because of the cost of their drugs, continue to forego those drugs because there are more pressing costs like food or housing or being able to heat people's homes. And of course, we're in a worse situation from that point of view than we were before the pandemic, because so many people have lost jobs and therefore lost the job associated drug coverage that they had. We've also undergone this really interesting period where pharmaceutical companies have been heroes, right? This has been, you know, we are all enormously grateful for pharmaceutical innovation. Innovation, I will say, that largely comes often from the academic sector, but nonetheless, we have been the beneficiaries of literally decades of research that has led to the ability now in this remarkable time to see these vaccines that have been developed, and mass immunization, nothing that any of us have seen before. And so one has to sort of think about what that has done to the public sentiment. And, the manufacturing sector has been incredibly important. Of course, it's also been brought to our to our attention that Canada has actually not had a strong biomanufacturing sector. And it's actually given us an opportunity to talk about why that's the case and what we could have done differently in the future to make ourselves less vulnerable at a time like this. And so we've got on the one hand the fact that the pharmaceutical industry are heroes, and we've got on the other hand families that are less and less able to actually be able to afford their medications. And it's a time when it's easier than ever, I would argue, for drug manufacturers to try to make the case that we have to continue to spend a lot of money because that's the money that allowed them then to do the research and development, theoretically, that's led to things like the vaccines. Well, I think it really needs to be said in the context of the conversation that we're having, that the research and development investments that have led to coronavirus vaccines have been heavily subsidized by the public. And ought to be very clear, and this narrative has not been out there loudly enough, although a shout out to Dan Raza, who's tried to make the case very well, and others, about the fact that we've paid for, we the public have paid for the research and development in order to see these discoveries happen, and then we're paying for these products again, either through, in the case of vaccines, they have been publicly funded here in Canada, but this is not always the case in other pharmaceutical products for which we've also been the ones that have paid for the initial investment. So I think it's relatively well known that the Oxford AstraZeneca vaccine, that the research was at about 97% publicly funded. The Moderna vaccine was a recipient of literally billions of dollars of public funding, and the Pfizer BioNTech vaccine also has had the German public who have paid a significant portion of the bill for that. And so I think this is a time where we need to think about who actually pays for drug development and how the prices of the drugs that we're paying for are driven by the fact that that industry has said continue to increase prices. And so we've seen here in Canada an enormous amount of public investment over decades of time underwriting private drug development, and the recoupment of, or the recovery of those costs for Canadians is rarely to the extent that it ought to be. And I give you this background because it leads into the conversation around the regulations that the Patented Medicines Prices Review Board has had, and which have been, there has been a multi-year effort to try to address drug pricing. The Patented Medicine Prices Review Board was implemented at a time when Canadians were policymakers were convinced that there would be a link between the amount that we pay for the drugs that we have and how much industry would invest in research. And so this review board, the PMPRB, was established more than 3 decades ago, a way to protect ourselves, to protect consumers from high drug prices and still have a fair deal so that the companies could invest in R&D. But in fact, that deal has not actually borne out what it was supposed to do. The idea was that we would set benchmarks for the top price that would be paid to countries like the US because the US was seen to be a place that had high research research productivity. But in fact, in 1998, R&D spending in the industry was almost 12% of pharmaceutical sales. And in the latest data that we have, it's now less than 4% in R&D. And so we are now guided by evidence that there is no link between a drug's prices and a company's amount that they will invest in R&D. And so when I was Minister of Health, we did a lot of work on trying to change some of the regulations. We actually released a policy document called Protecting Canadians from Excessive Drug Prices. It was actually designed to be a preface in the minds of many people to preparing for national pharmacare and rolling out a national formulary. We tried to do three things through those regulatory changes. One was to change the list of comparator countries. Number two was to require that there had to be proof of value for money if new drugs come along, that they couldn't just charge more if they were actually Me Too drugs. And the third thing was to establish a level of transparency for the confidential price reductions that are negotiated through a variety of rebate mechanisms. As some of you will know, there has been, continues to be an enormous amount of pushback on those regulatory changes. One of them actually ended up getting dropped, the requirements for transparency on confidential price reductions. This blueprint, which essentially would have saved billions of dollars, has continued to be fought and delayed and weakened, it's unfortunately seen to be almost off the table as part of, as well as the fact that pharmacare in its universal public form has been apparently almost set aside. So how do we deal with that now? How do we actually renew things? Well, I think we need to renew our overall relationship between government, academia, and industry. We need to reimagine that relationship. It is long past time that Canadians demand stewardship of the investments that are made on behalf of the public, so that when the public is investing through our health research mechanisms, through investments in academia, that we protect the intellectual property that accrues in the development of new medicines and technologies, and that there be therefore fair pricing of pharmaceutical products and a complementary reinvestment into the public system. So I share all that not because it's exactly what we're talking about tonight in terms of pharmacare, but it is in the minds of government and in the minds of policymakers at Health Canada. I can tell you that it's part of the conversation about how we're going to get to universal pharmacare. There's certainly a strong desire, has been a strong desire not to lock in high drug prices. And so I encourage you to learn as much as you can about the way that drug prices are set in Canada, and be an advocate for the regulatory changes that will keep prices low, because in the long run, it's going to be to everyone's benefit. What other things do I think that we can do, and what other ways, how else will we build that political will? Well, I think you got some hints from the things that Steve talked about. Political will is built by the people, and who are the people that are going to benefit? Well, of course, Canadians are going to benefit. The people who will not have to forego food and heat and housing. Private sector will benefit. Large companies that pay an enormous amount of money right now through their drug plans will be beneficiaries, and they ought to be a big part of the advocacy work that's done by groups like the Canadian Doctors for Medicare. I would encourage all of you to continue to do the work that's necessary to bolster public support by hosting events like this and telling stories of the people and the patients that you've encountered who have had to forgo medications. I would also really push some of the associated policies, in addition to the regulatory changes on drug pricing. The work around the national formulary is something that is an essential step towards the national pharmacare, and has not had the amount of attention that it ought to have. And so I think that's one of the areas where advocacy organizations can spend some of their energy. And as some of us were talking about just before the program started tonight, the provinces on board. Provinces, again, will be huge beneficiaries of this investment of the federal government, which will ultimately benefit all Canadians. But getting provinces to demonstrate the efficacy, and therefore for Canadians from those provinces who see a universal public single payer public plan will be part of the building of the public support that's necessary to lead to the political will overall. So my final messages around advocacy are to always do so with respect, to always work across parties. There's no single party that has an entire monopoly upon the policies around pharmacare, and every thoughtful politician will be open to hearing your voices. So don't abandon anyone in the numbers of people that you try to reach. And I will just tell you that there is absolutely no substitute for Canadians from all walks of life going in and talking to their members of parliament, and during a campaign talking to their candidates from all parties to say pharmacare matters to me, and I will support you if you will support pharmacare. So I'll leave it at that.
Thank you so much, Jane. That was fantastic, and I think you already answered a bunch of the questions that have been coming into the Q&A, so that's fantastic. Now we'll turn over to Linda. So Linda, you and CFNU members have worked very hard on this issue for many years. Can you speak a bit to why this issue resonates so much with nurses? And what have you heard from your members and from the public about why this matters to them?
Thank you, Tara. Hi, Jane, Steve. So happy to be here. I'm coming from Ottawa, beautiful sunny Ottawa right now, which is the unceded territory of the Algonquin and Anishinaabe people. I wish I knew the history like Jane did. It was quite interesting to hear about Kingston. And for all the panelists, I send the 215 families our broken hearts in Kamloops, but the families of the families of the families, we're talking about many generations, and we have to send thoughts and prayers tonight and for many, many more nights there. Why are nurses so confident that we do need a national pharmacare program, and that we've been at it for the last 20 plus years? I have to say, one of my first national forum was the 1997 National Forum on Pharmacare. And my eyes were opened by all the science, by all the reasons on why we needed a national pharmacare program. And then we had Romano, then we had ESSA, then we had Oskin. I said to Dr. Eric Oskin, I'm going to be at that pharmacare party, I guarantee you. We're not there yet, but we will. The reason why nurses are such advocates for pharmacare, it's we see the reality every day, just like docs. You see the reality every day. Doctors have, some of them, and we have an ability to give samples once in a while. So it's kind of a teeny little Band-Aid that you're able to do, give samples to 1 in 5 Canadians who can't take their prescription drugs, who have to split their pills in 2 or 3 just because they think they're doing something. On the flip side, we also see the waste. And I don't want to talk COVID-19, but I almost have to talk COVID-19. If you think we're in a health crisis now because of this virus that has hit our shores, that has hit all our communities, just wait. The backlog of surgeries that are coming our way, the backlog of treatments, of tests, the shortage of nurses, of doctors, of anybody who's on the curbs of retirement is saying, I'm getting out of here. Our new crop of nurses and doctors are saying, not sure if I want to work full-time in that system that is so crazy. We see the waste every time. And when Steve talked about the $1 billion, which came from the Hoskin report, that the hospital system could save. Imagine, he just talked about doctors, 25,000 doctors, which that's nice and dandy. But imagine what we could do if we could reinvest the money we're spending for prescription drugs, I should say, and not covering everyone, that we could reinvest. Think about the long-term care sector. Think about what all the provinces, territories, and the federal government are going to have to do in the next years to fix what COVID-19 did to our system. We need to be better. And for those who are doing social media out there, you need to quote Dr. Jane Philpott. Canadian needs to demand stewardship on prescription drugs. And we have to demand, and we have to be so precise on what we're asking for. And I should stick to my my notes because I'll go on and on. But you all heard the stories, and we've heard even worse stories during COVID of people losing their jobs. You know, from a 25-year-old man who used to travel from Alberta to the Maritimes, lost his job, had ulcers, couldn't afford his ulcer medication, end up in surgery. The diabetic that can't afford their diabetic medication end up in hospital. Asthmatic children, parents can't afford their medication. Dr. Philpott talked about that during COVID, we're seeing more and more families suffering because they can't afford the prescription drugs. What we do know is double the amount of workers lost their coverage compared to got their coverage. And as most of you know, I'm president of a national union. So what I've done most of my life is at the bargaining table. And at the bargaining table, the health coverage is a big chunk of our negotiation. It's a big chunk because the cost goes up and up and up. It's been estimated it's about 12% of your hourly rate. So imagine how difficult it is in these times to go negotiate. We have to negotiate and try not to reduce the benefits. You heard Steve talked about there's over or close to 100,000 different private plans. There's nothing more stressful and confusing for a family to change health plans. To go to the pharmacy and to say your copay has changed. No, this is not covered. My last one, I was going to New Brunswick and I asked, oh, can I have 3 months? Oh, they're not covering that for 3 months. You want to pay the difference. And it was like every time, and that's just me. I just take one cholesterol medication, full disclosure here. And you have to think, what about the rest of the families and what happens? So we just have to know that, yes, Jane talked about during the early days of the pandemic, we were sure we were there. Because yes, it's a political dance. Yes, we have to work with all parties. Some are harder than others, let's be real. But I was at the Liberal convention when they passed that famous resolution. I was at the NDP convention when they passed that famous convention. I wasn't able to attend the Green Party, but they passed a resolution on pharmacare. Steve represents over 200, almost 300 academic that signed statements saying that's what we need. Heart and Stroke joined organizations like the Canadian Labour Congress, CFNU, and so many others to convince the government. So let's remember Jane's last word. We have to demand stewardship around not only the cost of prescription drug, but the access. And remind all politicians of all stripes, stop playing the political ball. Oh, this is really provincial, territorial responsibility, federal. Under the Charters of Rights, it is all government's responsibility to provide healthcare services, which includes your prescription drugs, and which we have to remind politicians that it's prescription drugs. And healthcare doesn't end when you leave your doctor's office or when you leave the hospital. So I'll try to wrap it up that way and answer your Q&A. But again, both Jane and Steve and Tara said the importance is to keep on talking about it. The importance is to keep on. I can't wait for the next Council of Federation, which is the annual meeting of premiers from all the provinces and territories, and look at them in the eye. How can you tell your citizens that 1 in 5 families can't afford their prescription drugs? How can you waste $1 billion of my tax dollars and not provide the right services? and start that ball going again. And we will get there. Thank you.
Thank you so much, Linda. I think that's the soundbite for this evening. Healthcare doesn't end when you leave the hospital. I love that so much. Thank you all very much for giving us that excellent overview of pharmacare in Canada, where we're at and what's likely to come. So now we're going to move into the Q&A session of this evening, and I can already see that I think we probably have more questions than we can get to, but we'll pick a few of them and try to get a bit of a diverse range of questions in. And then for anything that we don't get to, I apologize for that, but we will try to reach out to individuals with responses at a later time. And hopefully some of the questions have already actually been addressed a little bit by the panelists. So this first question, which was sent in to us in advance, is what investments does the federal government need to make in 2022, 2023, or even earlier to begin implementation of a national pharmacare program? In other words, is the $35 million over 4 years promised in budget 2019 too slow? And that's for anyone who wants to speak to that.
I'll take it. I'll take this on because I think, we've got a terrific blueprint in the Advisory Council on the Implementation of National Pharmacare's report. It is detailed, it is politically strategic, and it is logically coherent. I provided them some advice, but I can take no credit for how well they delivered that report. It's everything I would hope for and more in a government document. What is required then is to follow through with the development of something akin to the Canadian Drug Agency, which has been talked about for many years, and that is an agency that can have the capacity to develop a national formulary and, most importantly, negotiate the supply contracts and prices for the medicines on that formulary. That's a difficult business that's currently being done by CADTH and all of the provinces and territories on their own and in collaboration through what's called the Pan-Canadian Pharmaceutical Alliance. Those processes and skills can be united into an agency that would then need to have a budget. And so to your budget question, Hoskins suggested that the right way to start this off was with $3.5 billion in the first year. That would be 2022 for the federal share of an essential medicines list that would be covered for all Canadians. The provinces have balked on that, saying that they need more money for healthcare without strings, and so they say that's a non-starter. So I think the way to go around this is actually for the federal government to fund the entire cost of an essential medicines list for Canada and make that available for free to every resident of any province willing to play. That will immediately get the provinces on board because they would save approximately $3 billion in public spending on those medicines that they would otherwise have to pay for anyhow. So that's a $3 billion windfall for the provinces and then approximately a $9 to $11 billion windfall to Canadians if the federal government took it on. So I think if you want a really bold, ambitious way to get this program off the ground, it's actually for the federal government to pay for the first big step and then tell the provinces that they will join them hand in hand to build that program far beyond just a list of 100 or 200 medicines.
The only thing that I would add to that is that I think we need to find out what party Steve Morgan is going to run for and get Steve Morgan as the next Minister of Health federally. So maybe he can run as an independent and then become a Minister of Health. I'm not sure how that'll work, but we're very lucky to have somebody that has that kind of understanding of what it will take. Of course, as he's pointed out, the roadmap's been written, but somebody needs to have the will to follow it.
Steve, don't you dare, because they'll tie your hands down. And that's what happens. We all want great people in politics, but I think the smartest politicians listen to everyone, and they need the Steve Morgans of the world to whisper in their ear with the facts. You have the Linda Silas of the world that will push agendas and will continue pushing agendas. What has changed over my career as a lobbyist, or an activist. I shouldn't call myself a lobbyist. Whoa, what did I just do? But as an activist, is that we now mix the need of Canadians, the need of nurses, with the science. And that's where the Steve Morgan comes of the world. And we need to continue that. So to answer to your question, was there enough money? It's billions of dollars. It's a lot of zeros. So for ordinary Canadians out there saying, oh my God, just like the childcare debate, oh my God, it's so big. The key for the federal government is to start, to talk about it, to make sure they have the plan. And we all tried to influence that plan. We didn't agree with it with 100%, but we all signed on. And just for the federal government to realize that all the advocates for a national pharmacare program signed on to the Oskin report, even like I was against a copay, said, okay, I was against that it was going to take until 2027 to have 100% coverage, but it made sense. It was good, calculated steps that we could take. Well, if they drop the ball, we're going to backtrack 10 years. So it's not about the billions of dollars. It's about not dropping the ball and saying to Canadians, in 2022, we will have an agency that will develop a national formulary for all of you, for the provinces not to have their own little ones everywhere. So they'll be saving money there because we'll have one table of experts that will say, this is our national formulary. This is the essential drugs. This is what we're paying. And then the provinces can pay the extras if they want, or insurance companies can pay the extras if they want, but we will have the essential, but we can't drop the ball. And that will be our message to federal, provincial, and territorial government. Do not drop the ball on a national pharmacare program.
Thank you for that. And I think that leads nicely into the next question. We have an audience member here who was involved in the committee, in the Hoskins Committee on the implementation of pharmacare, and expressing disappointment that I think we all share that when a pharmacare program was tabled by the NDP, it wasn't successful in the vote. So I think paraphrasing the question, wondering if you guys have insights into why that tabled resolution was not successful, and then adding to that maybe what needs to be done differently the next time around to be successful, which will hopefully come up very soon.
I can take a quick stab, in part because I don't belong to a party, and I provide advice to them all. So that bill, which I helped actually craft some of the language for, was intended to put pressure on the Liberal Party of Canada, but it was not a pharmacare bill because the NDP doesn't have the privilege of introducing legislation that would have financial implications. The Liberals were never going to vote for that bill because they need to own the process and then the final delivery of a pharmacare program. It was a shame, actually, that some of the Liberal messaging was that they thought it might be unconstitutional to pass pharmacare, which is not true at all because we have Medicare, don't we? What they should have said was that there's no precedent for a major public expenditure to come into being through a bill that promises a subsequent bill in the same sitting of the Parliament. It's just literally no precedent for that. So it wasn't that I think the Liberal Party was necessarily against implementation. It's just that they need their timeline. COVID has thrown everything behind schedule. And I think the thing to do now is just to keep the pressure on the Liberals. And the NDP have been great with this. The Greens have been good with this too. Keep the pressure on them. Don't let them give up. Don't pretend that that was the death knell for the program. Just keep pushing, saying you promised it over and over again. We need to see it happen. And that means, backing things like the evolution of the Canadian Drug Agency and some of these price reforms, which are going to come under a lot of pressure. We got to, push on these things. But I've not lost hope. I still have a bit of hope that this might still come within my lifetime.
Within your lifetime? Sure, hope so. But
within the next couple of years, we hope, right, Linda?
I've been working on this for 25 years so far, so
what? But it's the political dance that we have to understand. But then there was COVID-19. You're talking about a big wrench. It's even hard for organizations like ours to talk about anything else. So I'm so refreshed when I'm invited to talk about pharmacare or childcare or women's issues. I'm like, okay. And I always promise myself, you're not going to mention the pandemic. You're not going to mention the pandemic. But it has changed. What we have to convince the politician that the new normal will include essential prescription drugs for everyone. Like we have to rejig and reposition ourselves that way. And it has to be part of our discussion, a continuous discussion.
And on that soundbite, we need not to stop at essential. We just need to let people know that it doesn't mean that sets the ceiling for public coverage. That just sets the floor for public coverage. You know what I mean?
Yeah. And yeah, we've always had that difficulty with what's the word essential. Is it bare minimum, or is it for nurses? It's having that advisory committee to decide what will be on the formulary. It's not up to Linda Silas to decide what's on the formulary. It's up to experts to decide what's on the formulary. Every minister of health in 2018 told us, we had a meeting, we had them all, please take that off our list, our job, because it's difficult when patients' families are knocking at their door and saying, put that one on our list, put that one. It shouldn't be up to a politician, and it shouldn't be up to an advocate like myself.
I'll add two other additional political thoughts for you all. As we, the reality is there's probably going to be an election September, October. Who knows what the new composition will look like? It may look similar to what it looks like right now. Never underestimate the power of backbenchers of the government. Okay, so whoever forms government, obviously, if you can get the ear of the prime minister, that's very helpful. But I actually think that getting the ears of large numbers of backbenchers can be enormously effective. The $5 billion that I got for mental health money in the health agreement that we made with provinces and territories in 2016 came because of the power of backbenchers who all wanted money for mental health. And they spoke with one voice, and they pushed their own government to be able to make it happen. The second thing I would encourage, again, this is like regardless of what party ends up in power, we need to encourage collaboration. So this whole point of the bill that the NDP introduced, maybe it was strategically smart. I don't know. As Steve said, it's never, it ends up, this is a very classic kind of games that you see happening where, the opposition parties want to try and, introduce a twisted version of what the government said they were going to do in the first place. And then they can say, oh, they voted against their own thing and they weren't really serious about it. I actually think this is so important. This is like not games worthy. This is like everybody's got to get on side. And we know that at least 3 out of the 4 major parties are in support of pharmacare in some format. They've got to stop arguing against themselves and figure out how they're going to work together to be able to get this over the line.
All right, everyone. Well, that was such an engaging Q&A session, and there's a ton of really great questions here in the chat that unfortunately we're going to run out of time for. Hopefully, I think most of them, our panelists have spoken to a little bit already just through their other responses, but we'll certainly go through these and try to get answers out to anything that wasn't addressed here. So with that, I just want to say thank you everyone for joining us tonight and for such an engaging conversation. To all of our panelists, thank you so much for taking the time to come out here and not just for participating tonight, but for all of the work that you do in this sector. Thank you to our audience for being so engaged. And I feel like we could honestly probably talk about this for a whole other hour and still not run out of things to say. So we'll have to hopefully get you guys back here again for another conversation.
And Tara, please, thank you for CDM and for all the docs out there. Join one of Canada's most progressive organization. So it's in the chat box, but thank you for keeping the discussion alive. So important.
Yes, thank you so much to CDM, to the tremendous ally on this file.
Thank you so much, everyone. And with that, I'll hand off back to Katie.
Yeah, I just wanted to echo that and say thank you so much to this panel. We clearly need to reconvene this group and continue this conversation, but ending it with more hope maybe than we began it.